Right, good afternoon, guys. I hope you guys are okay. Welcome back. Welcome to the MRCS Part A mock. I usually do focus on the MRCS Part B mocks, but for the we are launching our MRCS Part A services soon, so we are going to start the weekly mocks as well. So these weekly mocks will be completely free for all of you to attend, and this is my way of paying back to the surgical communities. When I was taking the MRCS exam a long time ago, almost a decade ago, there are a lot of, I was lucky to have a lot of seniors who helped me crack through the exam easily. So this is a way for me to pay back these mocks. So I usually run, as I said, Part B mocks. I've been doing these mocks for the past 7-8 years now, especially the Part B mocks. So I'm going to expand and then start the Part A mocks as well. So, well, many of you might have heard and already know who I am, but let me quickly introduce myself. My name's Miet. I'm a cardiac surgery registrar in London. I'm based at Barts. So if you're based in London and if you're around in the area, feel free to drop me a text and then we can grab coffee or something. At the same time, I'm finishing my PhD at the Imperial College London as well. So my focus is the especially the aortic arch surgery. Right. So I've been working in the NHS for the past pretty much almost 10 years now. So I've got plenty of experience. So what I like to do is during going through these questions, when we talk about the topics, I'll be sharing my own experience as well. And in fact, our brain is so accustomed to listening to the stories. And when you hear a story and associate it with a topic, that topic you'll remember longer. Right. So that is the strategy that we are going to take. So we, as I said, we run Part A and Part B mocks as well. So the Part B mocks are usually at 4 p.m. Part A mocks will be at 3 p.m. on Saturdays. We won't have a mock next week because I have got a on-site hands-on course in London for Master's Part B candidates. So I won't be able to run the mock next week, but the week afterwards and following weeks, you can check the mocks on our website. So this is our website, mrcsbootcamp.com. Feel free to go and check around. Join the Telegram and the WhatsApp group. So if you go to the online mocks page or just the mocks page on our website, you will see the links for joining both Part A and B groups. And then if you've got any questions, go and join the Facebook group on Facebook as well, especially if you're using the Facebook. All right. And like to tell you, we're launching the Part A subscriptions. They're not available yet, but we'll be launching for September cohort. So if you're taking the exam in September, feel free to consider these ones. And one of the unique things is you will see we use the AI-powered portal. And I believe we're one of the first in the industry to launch the fully integrated AI preparation for the exam. So without further ado, well, by the way, these subscriptions are coming in late 2025, May. So if you're interested, please feel free to come and join it. So we don't have the Part A portal ready yet. So what we're going to do is we're going to borrow Part B portal, which will be very similar in a way, and we're going to use it for the mock. So what I'm going to do is I'm going to share you the portal and then we will take it from there. Right, so I hope you can see the screen. I'm going to click on this one and it's not ready yet, so it will come in soon next month. So I'm going to log into the MRCS Part B portal and we will borrow at the very bottom then as a part mock. So we are, as I said, we are doing the testings and the final testings for this. So I'll quickly share you what is AI powered portal. So we keep saying AI powered portal, but many of you may not be very familiar with that. So this is what we're going to use. So these are the traditional questions, and this is the format that we're going to use for the mock. So I will display a question and then with the choices, obviously, and then I want you to actively participate. There's no point for me to open up one question and then show you the answer, open one question, show you the answer. It's no point. So I want you to actively participate. Even if it's wrong, doesn't really matter. What matters is you actively participate. So let's say if we're going to do this question, then what would be the answer? Anyone like to give it a try? This is not a mock question we're going to do, but this is just a simple example question. So it's a 39-year-old female presents with bilateral ptosis and fatigue. Evaluation of the mediastinum will most likely reveal what? Lung cancer, thymoma, lymphoma, metastatic thyroid cancer, Graves' disease. Which one would it be? Anyone? So I said, being right or wrong doesn't matter. Doesn't matter at all. So give it a try. What do you think? You have to unmute your mic and then jump in a discussion because I won't be able to monitor the chat when I'm running the mock. Right. So feel free to unmute your mic. Tell me what you think. So I said, doesn't matter what you think are right or wrong. What do you think is the answer? Come on.
I think it's A.
A. Great. So, by the way, knowing the answer is never enough. You have to know why the other answers are wrong as well. So why do you think A is the correct answer? Go on. Anyone?
I think it's because the cancer compress the thyroid thoracic outlet, I suppose.
So how would it explain the ptosis, for example? It's bilateral ptosis, by the way. It's not unilateral. It's bilateral, so the cancer must be present in both lungs, which I see is a little bit far-fetched, but cancer will explain the fatigue. I totally agree with that. Well, so since this is a bilateral problem, this usually indicates, if it happens bilaterally, this usually indicates it's a general problem, systemic problem rather than a local problem like lung cancer. Small cell lung cancer usually happens on one side unilaterally unless it's very late stages. So what you're talking about is something called Pancoast tumors. That's correct. If these happens, Pancoast tumors usually appear at the apex of the lungs, then they would compress what? To cause ptosis. What would they be compressing? Anyone?
Cervical plexus.
Very good. Sympathetic chain that extends above the neck. So that is superior, middle, and lower sympathetic ganglion. And if it compresses sympathetic chain, loses the sympathetic control of the eye, which innervates levator palpebral superioris. And that paralysis will lead to the ptosis. But as I said, bilateral is a bit rare. So we have to think a bit more systematically. So small cell lung cancer, it may be possible, not very obvious. Thymoma. Would it cause the problems? Mediastinum. The answer is yes, very much so, because thymus lies in the anterior mediastinum. And thymoma is usually related with which systemic disease? So let's start with the thymus. What does thymus do? Anyone? Jump into the discussion, doesn't matter whether it's right or wrong, as I said. What does thymus do? No. So thymus is university for T cells, meaning T cells goes to the thymus, and if they cannot bind the foreign antigens, they get killed off because there's no use for T cells who can't bind the foreign antigens. That's the first step. That's a positive selection. And then the next step, they go through the university progresses, and then before graduation, they get killed off if they bind to the self antigens, meaning if they're binding to the body's antigens quite avidly, they get killed off as well. Otherwise, what will result are the autoimmune diseases. For example, in this case, ptosis and fatigue can be explained by a systemic disease, like in this case, what I would think is myasthenia gravis. And myasthenia gravis is associated with thymomas. So this more fits the clinical picture. The next is a lymphoma. Again, lymphoma are quite confined. Most of the time they're confined to one group of lymph nodes, or 2-3 group of lymph nodes, but in the same region. So that's a little bit difficult to produce pyelonephrosis as well, but it will definitely produce fatigue. Metastatic thyroid carcinoma can compress it on the recurrent laryngeal nerves. I'm sorry, beg your pardon, the sympathetic chain that's traveling on the side. But again, to have compressor on both sides, it's a little bit far-fetched as well. Graves' disease is an autoimmune disease, and it doesn't usually compresses on the nerves, but rather causes what? What is the characteristic finding in Graves' disease?
Ophthalmoplegia.
Okay, so it's hypothyroidism. What? Because of the excessive stimulation of the thyroid hormone. So let's see what we're going to find. Right, so the correct answer is the thymoma, because thymoma is strongly associated with the myasthenia gravis and can present with pyelonephrosis, fatigue due to autoimmune release factor in the neuromuscular junction, and they're located in the anterior mediastinum. As a result, that explains things. Small cell lung cancer can cause paraneoplastic syndromes, but again, it is not typically associated with a bilateral ptosis or myasthenia gravis, which usually fits in this clinical picture. Lymphoma, they're still in the mediastinum. They could present as a mediastinal mass, but again, they cannot usually cause the ptosis. Metastatic thyroid cancer is the same, Graves' disease, and can cause the ophthalmopathy. Like, what kind of ophthalmopathy does it cause? Graves' disease makes the eyes. Does what?
It's ophthalmos.
Very good. Looks big. Exophthalmos, because that causes swelling of these soft tissues around the eyeball in the region that houses the eyeball, and then pushes the eyeball forward, making the eyeballs more prominent and larger than usual. Right. So that is pretty much of it. So this is the format that we're going to take in this mock. So I aim to do about 20-30 stations in each mock, depending on the time that we've got. So we'll be going through these ones. And the second type is the, well, this is kind of like the exam questions, right? I'm just gonna do a sample thing. So if it's correct, it's correct, it's not. So this is for the mock that will come later on. These are the timed mocks that we're gonna use later on. Great. So the other thing is, what is the AI powered preparation you keep talking about? So this is powered by Bootcamp AI. Let's say, for example, well, let's cheat first, right? What I'm going to do is I'm just going to copy and then paste it and then see if it gets the answer right. So it does. Right, the answer is B, thymoma, myasthenia gravis. And why they think it's not quite correct, it's explained to you as well. And then I want to know, for example, I can't really remember what myasthenia gravis is. So what I can do is I can ask a follow-up question. And then it will take you all the information and all the brief points that you need to know. And you would have a brief, what can I say, a brief revision before, without needing to go to the other pages and try to look for through browsing through the website and stuff. One of the things we do is once we start browsing the website, then we get lost in these information and then we don't come back to the study materials. All right, so that is what we're going to do. So let's go back and then start our mock today. So the first question. So as I said, we're going to do about 20-30 questions depending on the time that we've got. Okay, so what do you think? So this is a 6-year-old child playing with his father at a pig farm. Later on developed bloody diarrhea, painful red nodules on the limbs. Surgical laparoscopy excludes the appendicitis, meaning the appendix normal. What is the most likely cause of organism? So which one will be associated with this one of the keywords, pig farm? And secondly, causes bloody diarrhea as well as painful red nodules. And next, it had to be, the appendicitis had to be excluded, meaning that it must have a very similar presentation for the appendicitis as well. So which of the organisms? What do you think? Anyone?
The first one, Yeah, Yersinia.
Very good. I think that is the correct answer. Correct answer is Yersinia enterocolitica. Enterocolitica. It's, as I said, pigs. It's a very, very important keyword for you. When you're reading the stem, you have to pick up these keywords and the hints that will guide you towards the correct answer. And as I always say, knowing the correct answer is usually not enough. You have to know why the other answers are wrong as well. If you don't know why the other answers are wrong, you are simply no more than guessing. And probability is not that great if you've got 5 choices. Right. So the first one, this is the answer because it's related to pigs and can cause bloody diarrhea and also erythema nodosum. And that is what presented as a red tender nodules on the limbs. It also mimics the appendicitis. That's why the stem says appendicitis was excluded on the laparoscopy. And then we'll look at the wrong answers. One is Staphylococcus aureus. Well, Staph aureus can cause a lot of a range of problems, and Staph aureus usually found. Where do we find Staph aureus? Anyone?
In the skin.
On the skin. Very good. Let's say if you scratch your skin and the next day you find there's a small pus collection in the skin, that is caused by Staph aureus, because Staph aureus will cause pus, and that is a main characteristic. It can cause the food poisoning and cause vomiting and diarrhea, but rarely bloody diarrhea. And definitely it does not cause the erythema nodosum. So that's why it's wrong. The next, Campylobacter. It can cause bloody diarrhea, but it's no way related to the pigs or erythema nodosum, and making Yersinia more likely for that. The next is the E. coli. E. coli, one of the variant, EHEC, can cause the bloody diarrhea. But again, it's nothing to do with the pigs or erythema nodosum. And lastly, Entamoeba histolytica. And it's an amoebic abscess, and even it mainly affects the liver. And it doesn't, it can cause bloody diarrhea, but it doesn't usually do that. And it's more common with the endemic regions, meaning that there should be prevalence of Entamoeba histolytica around that region. Again, nothing to do with the pigs or the erythema nodosum. So the answer is Yersinia enterocolitica. Right, so let's go to the next question. A man sustains bite injury to his arm during a physical altercation. Which organism is more likely to be present in the wound? So, well, he got in a fight and then got bitten by a human. In other words, it's a human bite. Human bites, which organism? Anyone?
D.
D. I believe that's the correct answer. Echinella corrodens, very, very unique organism. Is very, it's associated with human bites or clenched fist injuries. For example, a person hits the other person and got injured by the teeth, for example, and then got abrasions on the hand, later on get infected. This is a flora found in the mouth of the humans, and it doesn't usually cause problems, but if it's displaced to other regions of the body, then that causes problems. And that's true for all the organisms. If the flora is found in where it's supposed to be, then that's okay. But flora somehow got displaced to other parts of the body, and that's where they can start causing diseases. So Echinella corrodens is the correct answer. And then we need to look at the other wrong options. So Bartonella. Bartonella is very famous for cat scratch disease, and it's a granulomatous disease causing granulomatous infections and stuff. So Bartonella, you have to remember the cats. The next Pasteurella species. Pasteurella species, both Maltosida and Canis, are for the cats and the dogs. So Canis, canine, if you remember the Canis, it's a Latin word for canine. So it's more related to the dogs, and Maltosida can be caused by both cats and dogs. In other words, if it's a dog bite or cat's bite or the dog bite, then you have to think about Pasteurellas. And lastly, Staphylococcus bovis. Staphylococcus bovis is quite a unique organism, and it's a flora found in the colon. And what usually happens is they don't usually cause problems. But if they cause problems, it's usually associated with what? Anyone? If you see Staphylococcus bovis for the rest of your career, I'm talking about for the rest of your career, you need to remember one thing, and that would be
Colorectal cancer.
colorectal cancer. If there is infection with the Staphylococcus bovis and the patient is fairly in the region of malignancy, for example, the patient's not young, right? Patients are elderly and present to you with a Staphylococcus bovis infection, for example, and infective endocarditis. One of the first things that you need to rule out is colorectal cancer because of the cancer. This is due to translocation of the Staph bovis from the colonic lumen into the bloodstream or any other area and causing the problems. So Staph bovis, always keep colorectal cancer at the back of your mind. These patients would need to undergo colonoscopy at a later date. All right, great. So human bites, Echinella, corrodins, cat scratch disease, Bartonella, cat bites, Pasteurella multocida, or dog bites, and particularly dog bites, Pasteurella canis, and Staph bovis is more like gastrointestinal flora. Next. A 60-year-old woman develops abdominal pain while eating pork sausages and eggs. 6 hours later, diarrhea and fever. Sellotape analysis identifies flagellated organism. So these are the keywords. So she had sausages and eggs, and 6 hours, which is not a very long time, started to have diarrhea and fever and flagellated organism. So which one's the most likely organism?
Salmonella?
Salmonella, great. Anything else? So let's start with the flagellated organisms. We know some of these are flagellated, some of these are not. So the correct answer is Campylobacter jejuni, by the way. One of the main reasons is that Salmonella has got longer incubation time. And although it's a flagellated organisms, its symptoms is not that rapid onset, like 6 hours afterwards. So on the other hand, Campylobacter, Salmonella, and Entamoeba histolytic, Entamoeba is a protozoa, so it's not flagellated. So Campylobacter and Salmonella, these are the bacteria that cause that are flagellated. So even if you know that fact, now you have reduced your chance to 50-50. E. coli, definitely not, because it's not flagellated and it's not used with the sellotape analysis to identify the E. coli. We would rather culture the E. coli. The same with the Streptococcus pyogenes. Again, it can cause, it's not a flagellated organism and it can cause gastroenteritis, but since it says flagellated, so it's already ruled out as well. So these two are out. Entamoeba histolytica, it's a protozoa, and it is not flagellated, obviously. And it's written incubation period is much longer, weeks as well, and it is more common in the endemic regions. So this is out, this is out, this is out. So we've got Campylobacter jejuni, which is the most common organism, especially from undercooked meat, especially in this case, eggs and the pork sausages. And the typical incubation period is relatively short, but especially when you eat a lot of these high input, then it can lead to pretty much within a few hours and then start problems. So Salmonella versus Campylobacter jejuni. So we're going to go with the Campylobacter jejuni. This. Great. Next. So what do you think?
Clostridium.
Okay, great. Any other questions? I mean, any other answers? Bacteroides, okay. Anyone else? So let's start. 59-year-old diabetic woman. Right, that's your first keyword. 59 is relatively elderly. Diabetic is immunocompromised. Undergoes abdominal ultrasound for recurrent abdominal pain, which reveals gas in the gallbladder. Oh no. this is really, really bad. And the keyword here is a gas and diabetes. So immunocompromised patient with gas in the gallbladder causing what? Meaning gallbladder is inflamed. What do you call the inflamed gallbladder?
Cholecystitis.
Cholecystitis. What's the most common cause of cholecystitis?
Gallstone.
I mean, in terms of the organisms.
Don't know.
E. coli. Right. When you see the E. coli, either stools, urine, or the bowel, you have to think about three things, E. coli. Otherwise, E. coli is not found very much nowhere, but in these things. Right. But the problem is E. coli doesn't cause gas in the gallbladder. So E. coli is out. Klebsiella can infect it, but it's out as well because it doesn't cause gas. Campylobacter mainly causes the diarrhea and gastroenteritis, not the gallbladder disease. So that leaves as Clostridium and Bacteroides A versus C, and especially Clostridium perfringens. We know that this is gangrenous producing bacteria, meaning gas producing bacteria, and the answer would be Clostridium perfringens. It's a gas forming from positive anaerobe, and it can cause emphysematous cholecystitis, especially in diabetes patients. And it will be visible on the imaging as well. So E. coli is probably the most common cause of acute cholecystitis, but very, very extremely, very rarely it will cause gas forming cholecystitis. Bacteroides, it will cause a lot of problems inside the abdomen because it's an anaerobe. And many of the collections and the infections inside the abdomens are caused by Bacteroides as well, but it does not produce gas either. So I said gas is one of the keywords, right? Klebsiella, again, it can cause the biliary infections. It's a gram-negative. Klebsiella and what's the other one? Proteus species. So these are commonly serious cause of biliary tract infections, but again, they rarely causes the gas formation. And Campylobacter, well, we just saw the one of the questions. It's commonly causes gastroenteritis rather than the biliary tree infection or gas producing things. So recapping, Bacteroides and perfringens, we're going to go with the perfringens because it's a gas forming bacteria. All right, let's go to the next. So what's the answer?
B.
D. Gentamicin.
No, B.
B.
B. Yep.
B for linezolid.
Yep.
So right, tell me why. Why
So
not B, for example? Why not E? Or why not D? Well, A is out, obviously. The patient's allergic to penicillin. So A is out because it's a penicillin. So we've got 4 choices.
It could be gentamicin or cephalosporin.
So the other question is, if you notice, cefuroxime is the 2nd generation cephalosporin and cephalosporin. So this is in the same group. If one is out, the other one will be automatically out. And cephalosporins will be out. Why?
An allergy.
Why would cephalosporins should not be used in patients with penicillin allergy?
It can cross, what's that called? Cross react.
Very good. There is a small chance there is a 20%, about 20% if I'm not wrong, cross reactivity between the penicillins and cephalosporins. Ultimately, they are from the same class, cell wall synthesis inhibitors. Well, so that's why, especially when the patient has got a documented penicillin allergy, this one would be out as well. So we've got 2 left, linezolid and gentamicin. Which one are you going to go with? So protein synthesis inhibitors. What are you going to go with? Linezolid and gentamicin.
Gentamicin.
Well, let's go and find out. The answer is linezolid. Right. I'll tell you why in a minute. So correct answer is linezolid, because linezolid has an excellent gram-positive coverage. And one of the common organisms in infective endocarditis is what causes infective endocarditis commonly?
S. Epidermidis.
Very good. Staph epidermis, Streptococcus and Staphylococci species mainly. Both are gram-positive, and it has got a strong coverage for the gram-positive. On the other hand, gentamicin is a strong gram-negative coverage and usually lacks sufficient efficacy against the gram-positive organisms. That's why the answer is linezolid. But depending on what organisms comes out in the infective endocarditis, we do use gentamicin a lot in infective endocarditis as well. Right? As you may remember, I'm a cardiac surgeon by specialty. So we do use a lot of antibiotics in different things, but most of the organisms are gram-positive. That's why we lean towards it. So if we go back and look at it, culture sensitivity shows amoxicillin, meaning amoxicillin penicillin groups is strong coverage for both gram-positive and gram-negative, but more towards the gram-positive thing. So that's why if we are to choose gentamicin, we will not be covering gram-positive much. That is the reason that we didn't go with gentamicin. Cefuroxime is a second-generation cephalosporin. There's a risk of cross-reactivity, the same with the cephalosporins group, the rest of the cephalosporins. Cefazolin, cefuroxime, all of these are the same group. So we should not be using with a documented algae. Amoxicillin is already out. So gentamicin, linezolid, gram-positive, we're going to go with the linezolid. Next. What are we going to do? What's the answer?
A.
Okay, why A?
I think it's cellulitis.
Very good.
A. Pyrogens, yes, cellulitis.
Why not C, for example?
I would actually go for C.
Right, so if we look at it, these are usually you can rule out a few without much of a doubt. But once you come down to two, that's quite confusing. Right, so let's have a look at it. 22 years old male, presented with a wound on the forearm, erythematous and rotten tender streaks, but no pus formation. Right, keep that in mind. And E. coli. We find E. coli in urine, in the stools, and in the biliary tree. So this doesn't really fit, and this is not a gram-negative infection. Clostridium difficile. What is the main disease that caused by Clostridium difficile? Anyone?
Gangrene.
Diarrhea.
Oh, no, it's diarrhea.
Diarrhea. What
Toxic
type of diarrhea?
colitis.
Yeah.
What type of diarrhea?
A toxic colitis.
Toxic colitis. And what do we call that? We call that pseudomembranous
Mm,
colitis, because it forms pseudomembranes. It secretes the toxins that causes the detachment of the mucosa and sloughing off and causing with the grayish plugs. And those grayish plugs are usually neutrophils because they keep inflammation, bacteria, dead tissue, everything sloughs off. And that's membranes are called pseudomembranous colitis. Well, this is quite a highly tested topic in both part A and B as well, but we'll talk about it later. But this is mainly geared towards the diarrhea. So it doesn't really fit the picture. Bacteroides, as we said, it's a anaerobe, a strong anaerobe. Whenever you see bacteroides, think of something happening inside the abdomen. Not again, this doesn't really fit the picture. So what's left is the Streptococcus and the Staphylococcus aureus. Streptococcus pyogenes, on the other hand, what's the other name? Which group is it? We usually call it
Group B. Beta hemolytic.
This is group A. Pyogenes is in the group A. So group A Streptococcus species and group A Streptococcus species are the main leading cause of cellulitis. On the other hand, Staphylococcus aureus will cause almost inevitably what? what formation?
Abscess.
Pus formation. That's why I'm going to go with A. Right. So, as we said, it's a very common cause of cellulitis, and it typically presents with erythema, swelling, warmth, and spreading rapidly. But since it does not cause any of the pus formation, Streptococcus staph aureus is less likely. But E. coli, Clostridium, Bacteroides are out. As we said, E. coli is primarily associated with GI, especially, well, some variants cause the GI problems, but particularly biliary tree, urinary tract infections, very, very common. Clostridium difficile is linked to antibiotic-associated diarrhea. That is pseudomembranous colitis. This is severe form. This is a milder form. What happens in the pseudomembranous colitis is the patient takes the antibiotics, and Clostridium difficile, is it found in the colon, by the way? Is Clostridium difficile found in the colon? Normally. Anyone?
Not normally.
No, not.
Answer is yes. Normally,
Oh.
it is found in the colon, and it is a very, very stubborn bacteria. I'll put it that way. So normal antibiotics cannot kill it. It's a spore-forming bacteria. So when the patient takes the antibiotics, the antibiotic kills off pretty much all the flora in the colon except the Clostridium difficile. Then the Clostridium difficile becomes monopoly and explodes its replications exponentially and causes problems. But Clostridium difficile is a normal flora in the colon. Bacteroides, always think about deep tissues or inside the abdomen. Next.
Bacteroides.
Right, 23-year-old male presents with a 4-day history of abdominal pain. Ultrasound reveals complicated appendicular mass containing purine material. Obviously, it's a perforated appendicitis. Which of the organisms? So, Streptococcus pyogenes usually causes the cellulitis. Staph aureus, again, skin infections mainly. Salmonella causes gastroenteritis and typhoid fever, for example. Clostridium difficile, again, something related with the gastroenteritis, especially pseudomembranous colitis. So that leaves the Bacteroides. And as we said, something deep inside, some collection inside the abdominal collection. In short, if there is abdominal collection, until proven otherwise, there will be Bacteroides. And it's not usually Bacteroides alone. It's usually polymicrobial, meaning more than one. But Bacteroides will predominantly be present there. So, very well done. It's a Bacteroides. It's an anaerobe gram-negative bacterium, common cause of intra-abdominal infections, including these, in this case, appendiceal abscesses. It's frequently associated with polymicrobial infections involving the GI tract. Pyogenes, cellulitis, soft tissue infections, not usually intra-abdominal abscesses. The same with Staph aureus, usually the skin, soft tissues, and wound infections, but not necessarily in the appendiceal infections. C. diff, Clostridium difficile, causes pseudomembranous colitis and antibiotics-related diarrhea, as we said briefly, yes, in the last question. And lastly, Salmonella. Salmonella can cause gastroenteritis, but not necessarily abscess formation and typhoid fever rather than the abscesses. Oh, I think there's an error coming up. Let's try again. I think I have to refresh the screen, so just give me a second, right? Right, sorry. So this is question 8. What do you think?
E. Trimethoprim.
Okay. Any other answers?
No, sorry, C. Nitrofurantoin.
C.
So yes, the answer is C. So let's have a quick look at it. So 54-year-old male presents with a painful urination, this is dysuria, low-grade fever, and it's not nitrates, in fact, it's nitrites in the urine. So why do we find nitrites in the urine?
UTI.
What does it tell you? More importantly, what does it tell you? Anyone?
Infection.
What kind of infection? Usually, it's a gram-negative infection. What kind of infection is most common with the urine?
E. coli.
E. coli. Very good. E. coli is the most common urinary tract infection, gram-negative one. And the nitrates, they are present in the diaphragm. And nitrates are usually, excess nitrates are usually discarded through the kidneys. So one passing through the urinary tract, if E. coli is present, they reduce the nitrates into nitrites by the gram-negative bacteria. So if you do the urine dip clinically and find out leukocytes and nitrites in the urine, that tells you that's a gram-negative infection. Leukocytes, but not necessarily nitrites, then maybe in rare cases that could be gram-positive urinary tract infection, which is not very common. But and then there is the patient's got pulmonary fibrosis. So what do we use for treating urinary tract infection? What's the usual things that we use?
Trimethoprim or nitrofurantoin.
Very good. Trimethoprim, usually together with the sulfamethoxazole as well. Or nitrofurantoin, depending on the sensitivity and stuff. So in the UK, especially even in London, different trusts have got different protocols. So either nitrofurantoin or trimethoprim, these are the first lines. And sometimes, especially when you're thinking about gram-positive bacteria, then amoxicillin together with the clavulanic acid or amoxiclav or augmentin can be used, right? Or ciprofloxacin will be used as well. Ciprofloxacin, we don't usually use the cephalosporins to treat the urinary tract infections, but sometimes they would be responding to cephalosporins like ciprofloxacin as well. So we can pretty much use all the medications to treat the UTIs, urinary tract infections, but the patient's got pulmonary fibrosis. So which drug causes pulmonary problems?
C.
Nitrofurantoin, because it can cause interstitial pneumonitis, and if patients continue to use them in the long term, it will cause fibrosis as well. And prolonged use as in more than 6 months. Or if it's less than 6 months, but patients using a high dose, then it can lead to pulmonary fibrosis as well. That's why patients with already existing pulmonary fibrosis, nitrofurantoin will be contraindicated in this case. Amoxicillin, it's very safe, nothing to do with the of the lungs. Cephalosporin, again, cephalosporins, nothing to do with the pulmonary fibrosis. Ciprofloxacin, again, very effective for urinary tract infections and doesn't have anything to do with the pulmonary risk. And trimethoprim, no pulmonary risk either. Great. What do you think? Anyone?
Surreal nerve.
Sural nerve, why?
As it goes in the posterior compartment after crossing the knee joint.
Okay, and how about tibial peroneal bundle? They go in the posterior compartment as well, isn't it?
Yeah, it also goes.
Huh. So, by the way, sural nerve is the correct answer. Right, let's start here. Which of the following structures you worry about during posterior leg compartment fasciotomy? Right, I've done countless fasciotomies during my vascular rotation, so I'll tell you how it's done. By the way, do you know how it's done? Let me ask you first. How is fasciotomy done?
It is an incision given in a compartment when there is a compartment syndrome or anything, and then landmarks given.
And how many incisions do we do?
Starting from the skin and deep to the fascia.
I mean,
For
how
that
many
single.
how many incisions? Is it 1 incision, 2, 3, 4?
For the posterior compartment, one incision.
So let's say compartment syndrome. Which compartment we can really differentiate which compartments in the leg? How many compartments are there in the leg?
In the leg, there are 3 compartments.
4 compartments.
Or
What are the 4 compartments?
anterior, lateral, and 2 deep posterior
Middle
and
and posterior.
superficial posterior.
Very good. Posterior compartments have got 2 deep compartments and the superficial posterior compartment. Right. So these 4 compartments, we need to decompress all 4 of these. So we don't necessarily know which compartment's causing the compartment syndrome. So how do we decompress these 4 compartments arranged in kind of like a rotatory manner? How many incisions do we need? Anyone? The answer is 2. We do it 1 on the medial side, 1 on the lateral side. The medial side, it will decompress both superficial and the deep compartment. And on the lateral side, it will decompress the anterior and usually the lateral. But again, it may vary. Some surgeons may be able to do it with 1 incision from the lateral side, but they would need to do the fibulectomy, meaning removal of the fibula. Now, so let's talk about this one. So which structures could be you're worried about? Posterior leg compartment. Tibioperoneal bundle, is it in the posterior compartment?
Yeah.
Yeah. Superficial or deep?
Superficial as well, I think.
Deep compartment. We'll talk about it later in a minute. Tibialis anterior
It's anterior department.
is in the anterior compartment, as the name suggests. Right. Peroneus tertius.
Anterior.
Very good. It's an anterior compartment just next to the extensor digitorum longus. All right. How about peroneus brevis and longus?
Those
Lateral.
are in lateral
Both
compartment.
are in the lateral
Great.
compartments of
Those
the
2 are the smallest compartment. That's the lateral compartment. Sural nerve.
Posterior.
It's in the posterior
Posterior.
compartment. Very
Posterior
good.
to
Nice.
lateral
Very
malleolus.
superficial. Short saphenous vein.
Lateral.
So which compartment would it include in? Would be included? This is pretty much both sural nerve and short saphenous vein. These are very superficial structures. Short saphenous vein is so superficial that it's not usually counted as part of the compartment. It usually lies above the fascia compartment, rather. So that is between the skin and the compartment of the fascia. So short saphenous vein, it starts where? Where does it start?
Behind the lateral malleolus.
Very good. Behind the lateral malleolus and drains into
Popliteal vein.
Popliteal vein.
popliteal vein in the popliteal fossa. Usually goes between the 2 heads of the gastrocnemius, just above the calf, right? Drains into it, and then that's it. So it shouldn't really be injured. Right? So we've got this one in the posterior compartment and this one in the posterior compartment. When we talk about tibioperoneal bundle, these are very big nerves. These are the 2 branches of which nerve?
Sciatic.
Sciatic nerve. Sciatic nerve is 2 centimeters. You can think about 2 centimeter nerve. That's the biggest nerve in the body. Not especially where there is a period tibioperoneal bundle where they start to bifurcate, the nerves are very big. That's why they need to lie very deep because the body needs to protect them. One of the deeper structures in the compartments are the tibioperoneal trunk. So unless you are doing fasciotomy from the skin all the way to the bone, which you shouldn't be doing it obviously, all you need to do is open up the fascia a little bit. So these deep structures are not likely to be injured, but sural nerve lies very superficial in the compartment, and this is going to be injured if you're not very careful. All right, I think there's a connection problem with my sorry, I just need to refresh it. I'm sorry about that. Right, sorry for the interruptions. Either my guys are working on the new portal. That's why I'm having a bit of server problems, or because my connection's playing out. I'm sorry about that. Anyway, so this is not the one. So this should be the one. 9. Great. Cerebral nerve. It's in the posterior compartment of the leg, and it's at risk of injury during fascial procedures. It provides sensory innervation to the lateral foot and the lower leg as well. Tibioperoneal bundle, it's in the posterior compartment, but it's very deep. That's why superficial fasciotomy shouldn't really injuring this one. Tibialis anterior, peroneus tertius, they are usually located in the anterior compartment, and this is located very superficially as well. Right, what do you think?
E.
E, cerebral nerve. So what
Cerebral
is
nerve, as it is in the posterior compartment. We're talking about the interior.
say it again?
Option E, sural nerve, as it is in the posterior compartment, and here the question is about the anterior leg
Very good.
compartment syndrome.
It's asking about the anterior leg compartment. So as we briefly talked about, extensor hallucis longus is together with the tibialis anterior, extensor digitorum longus, peroneus tertius is in the anterior compartment. Deep peroneal nerve. Which compartment does this apply?
Anterior.
Anterior compartment, very good. And peroneus tertius in the anterior compartment, dorsalis pedis again in the anterior compartment, except the sural nerve, everything is in the anterior compartment. So this is the answer is the sural nerve. Right, because the rest are not in the posterior compartment. Right, so
D.
D, medial to the biceps tendon. So this is simply asking about the anatomical, can I say, anatomical, oh, what's a word? Locations between, it's not locations, relations, anatomical relations of certain structures to another structure. So 26-year-old man presents to the emergency department with extensive bleeding from his arm following blast injury. 7 centimeter transverse laceration across the anterior respect of the elbow, meaning which fossa are we talking about?
Cubital.
What is written here?
Cubital fossa.
Cubital fossa. And what's
Mm.
inside the cubital fossa?
Bicep tendon.
Brachial artery and median nerve, and some tendons.
Brachial artery,
Median nerve,
median nerve,
bicep
tendons.
and the biceps tendon. How about the vein that we take the blood from? Antecubital vein. Is it inside the cubital fossa? The answer is no. The vein located in the subcutaneous tissue, that's why it's usually regarded as superficial to the cubital fossa or the roof of the cubital fossa. Oh, so which, in anatomical position, which structure lies most laterally?
tendon.
Biceps tendon, biceps brachii tendon. Which structures lies most medially?
Median nerve
Median nerve. So somewhere in the middle,
is brachial artery.
the brachial artery. If we're talking about the brachial artery, anterior to the median nerve, nope, we said median nerve lies most medially and biceps most laterally. In the middle is the brachial artery. Lateral to the biceps tendon. Bilateral to biceps tendon is nothing, it's out of the cubital fossa because biceps tendon lies most laterally. Medial to the median nerve. Median to the medial nerve, again, nothing's there because the median nerve lies most medial thing. Medial to the biceps tendon. That is the correct answer, D. Because brachial artery is in the middle, biceps tendon lies laterally. So lateral to the medial side, this is the answer.
Correct me if I'm wrong. Bicep, it is in lateral. Median nerve, it is medial to the bicep, to the brachial artery, right?
Say it again.
At the most lateral, it is bicep tendon. Then it is our artery,
Yes.
and then most medially, it is a median nerve.
Yes, that's correct.
Okay, and the vein is outside of the this fascia. It is in the
Mhm.
superficial to the skin. Yeah.
Yes. The next is a superficial to bicipital cord neurosis. Again, this is not correct. So the answer is medial to the biceps tendon, because biceps tendon lies most laterally, and medial to that one is the brachial artery. Right. So this is asking you the network relations. What do you think?
I think it's D.
That's B.
Okay. So first of all, let's start. Following supraclavicular lymph node dissection, 43-year-old man is unable to shrug his left shoulder. What shrugs the left shoulder? Which muscle?
Trapezius.
Trapezius. Which nerve innervates the trapezius?
11th cranial nerve, accessory nerve.
Accessory nerve. Accessory nerve. What is the sensory innervation of accessory nerve? What is the sensory innervation of accessory nerve? It's a trick question. There's nothing. It is a pure motor nerve. That's why loss of sensation is already out, because it's a pure motor nerve. Some of the nerves in the body, they are pure sensory. Some of the nerves are pure motor, and accessory nerves are one of them. Well, so what else accessory nerves innervates? Trapezius and?
Sternocleidomastoid.
Very good, sternocleidomastoid. What's the function of sternocleidomastoid?
To
Neck.
control it as side lift of face.
So sternocleidomastoid runs from the sternum to the mastoid. Mastoid's kind of like towards the back of the skull, right? So imagine all the muscles are the strings that pulls to one side, right? If you pulse this one, what's going to happen is the head is going to turn to the opposite side, because you're pulling something from the back. So that's the unilateral action of sternocleidomastoid. It turns the head to the opposite direction. If it contracts bilaterally, what will happen? Flexion of the head. Flexion of the head and neck, obviously. Right. So let's have a look at this one. Which of the following deformities would be expected? So we are only experiencing one side. So loss of neck flexion is not very possible. Why? Because there are other muscles which causes the flexion of the neck, not only sternocleidomastoid, but also the paraspinal muscles as well, for example. Inability to rotate face towards the right side or the left side. D, we've already kicked it out because it's a pure motor nerve. It doesn't cause any, it doesn't have any sensory innervation. And inability to shrug the other shoulder. Well, there are two accessory nerves coming down, and one's injured because of the lymph node dissection. It's a local problem. There is no reason the other nerve to get injured as well. So the other one should be able to shrug the other shoulder. B or C? Which one?
B.
The answer is B. Why? Because, as I said, the function of the sternocleidomastoid is to turn the head to the opposite direction. So the answer is B, inability to rotate the face towards the right side, damage to the spinal accessory nerve, which is the 11th cranial nerve. It's unfortunately, very common when you try to dissect the supraclavicular, as well as the anterior and posterior chains in the posterior triangle of the neck. When you try to dissect it, about 30% of the time, you'll end up injuring the accessory nerve, and it causes lots of problems. One of them is inability to rotate the head to the opposite direction. Great. So next.
A.
Okay. So again, which muscle is responsible for abduction above 90 degrees of the shoulder? So the shoulder is quite a unique joint where several muscles walk together, because shoulder, and by the way, what is the bony joint that attaches the upper limb to the trunk? Tell me one joint. Which joint is that?
Shoulder joint.
That's a wrong answer.
Acromioclavicular joint.
No, that's a wrong answer. It's a very, very interesting. The only bony joint that holds the whole upper limb to the body is sternoclavicular joint right here in the middle. There is no other bony joints. But of course, this joint is pretty much negligible in terms of the strength or the movement because you can't really move around. What does everything about the upper limb is around the shoulder, and the stability of the shoulder is maintained by the rotator cuffs. So rotator cuffs are very, very important. A lot of muscles and the ligaments maintain it, but anatomically, the only joint that connects the whole trunk to the upper limb is the sternoclavicular joint right in the middle. But anyway, in this case, abduction of the shoulder, lots of muscles. So the first 15 degrees is by the
Supraspinatus.
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 Remaining from 15 to 90 degrees is by the deltoid. Very good. And beyond 90 degrees would be
Trapezius.
trapezius, together with, there is another muscle that helps the trapezius do that.
serratus anterior.
Very good, serratus anterior. Both of them, along with the serratus anterior, rotates the scapula, and that's how shoulder is abducted beyond 90 degrees. Great. This one. A 32-year-old man falls on an outstretched hand, injuring the distal forearm. Unable to lift his thumb with palm facing downwards, meaning abduction of the thumb. When the proximal phalanx is fixed, he cannot move interphalangeal joint. Interphalangeal joint of the thumb. So there's only one muscle that goes to the distal phalanx. Which muscle is that? If you know that, you get it right. If you don't, probably have to walk it out.
Tensor pollicis longus tendon.
Extensor pollicis longus. It's the answer. Correct. So let's go through one by one. Radial nerve injury. Radial nerve injury, it's not only interphalangeal joint. Radial nerve injury will affect pretty much everything because a lot of the things, both sensory and the motor of the forearm, are innervated by the radial nerve, especially all the extensors will be injured. Next, posterior interosseous nerve injury. Again, that is not, well, let's open up the answers and then walk through this one. So radial nerve injury, as I said, it affects multiple extensors, not necessarily related to the thumb. Posterior interosseous nerve, it can impair the thumb and the finger extension, but it doesn't really affect the interphalangeal joint more specifically. Abductor pollicis, it's more like, what's the action? Abductor pollicis. Abductor. In the abduction, obviously, as well as helps with the flexion of the thumb. So lifting off the thumb off the table is the extension purely, and it's got nothing to do with that. So that leaves the extensor pollicis longus and the brevis. So extensor pollicis brevis ends at the proximal phalanx of the thumb, whereas the longus, because it's the longest, it goes longer. So it's longer, it goes to the distal. And especially when it says it cannot move interphalangeal joint, it pinpoints towards the longest tendon that goes towards the distal phalanx. That's why the answer is extensor pollicis longus. Oh, so we are running, the time's running out. So let's do our last question. So question 15. What do you think? So 34-year-old man had a road traffic accident, motorcycle accident, presents with weakness and sensory deficits in the upper limb. Examination suggests the damage to the brachial plexus. Which nerve is most likely to be spared? Meaning, the rest of the nerves are probably injured except one. What do you think? Anyone?
All nerves that belongs to the brachial plexus, if I don't think.
Axillary nerve, it's a shoulder injury. Axillary nerves wraps around the shoulder. A lot of things happens in the around the shoulder. These axillary nerves and the musculocutaneous nerve, these are out because these will definitely be injured if it's a motorcycle accident on the shoulder. So that leaves 3: radial, median, and ulnar. In terms of the roots, the correct answer is ulnar nerve. Why? Because the ulnar nerve comes out to the lowest in the brachial plexus and it hides under at the lowest level of the axilla. That's why if all these nerves are injured and want to be spared, I'm going to go with the ulnar nerve. So it's likely to be spared because the roots, if you remember the roots, that's a C8T1. That's the lowest root. Axillary nerve, as I wraps around the shoulder and supplies the little muscles around that area, and the skin, regimental badge area, is supplied by the axillary nerve itself. C5, C6, this is one of the very commonly injured nerve during the shoulder injuries, together with the musculocutaneous nerve as well. This is the main flexus. They supplies the main flexus of the arm. Right. On the other hand, radial nerve arises from the C5T1, but again, it supplies the extensors of the arm, forearm, and the hand as well. And as a result, it's got very high chance of injury as well. And the C6T1 median nerve, these are the flexes, but the ulnar nerve hides the lowest, and this is least likely to be injured. So this is the end of the mock because I'm continuing with the part B mock as well. So somebody asked in the chat how often we're going to do the free mock. So I would like to do this on a weekly basis. And next week, I won't be able to do it because I've got a on-site hands-on course in London for the part B. Otherwise, I will try to do it on a weekly basis. Feel free to come and join, come and attend. I hope I'll see you guys soon. For those who would like to review it later on, there will be a recording available on our website. I'll share the link later on as well. All right. Have a good rest of the weekend. Take care. I'll see you later. Bye-bye.